Welcome, friends, to the medical education channel for medical students and young doctors. Um, I'm Saleh Abbas. I'm Associate Professor of Surgery, and I have a lecture series about variety of issues related to general surgery, and hopefully in the future we will expand on other specialties. Today's topic is going to be about perianal suppuration and anal fistula. These two go hand in hand. Anal fistula and fissure, anal fistula and abscess go hand in hand because they often are associated in about 30% of the times. Now, perianal abscess, we need to understand exactly what it is. By definition, it is the infection of the anal gland, and there is about 8 to a dozen of them. They are situated in the interior sphincteric space between the internal sphincter and the external sphincter. And these glands drain anti-gravity, and as a result of that, the duct could get occluded, and because the area is contaminated, you could get a perianal abscess. Now, usually the gland infection or the abscess starts in the intersphincteric space, and then it could spread lead to variety of abscesses and their types by their anatomic location. So it could extend into a superiorly, which is unusual presentation, but it does happen, and go above the levator ani in the actual pelvis. They could spread laterally and lead to mucocutaneous fistula, and that can lead to mucocutaneous abscess. And we have the classical intersphincteric abscess, and we have the rectal abscess. The rectal abscess is an infection in the space, which is a pyramidal shape that's medially bound by the levator ani and laterally by the obturator internus that supports the pelvic wall. That space is fibrofatty, less vascular, and can get easily infected, and that infection can spread or open spontaneously or lead to a fistula formation. Now, supralevator abscess is a very uncommon thing to happen as a complication of perianal abscess. And if it does happen, you need to be aware that these patients could have other medical problems. That could be Crohn's, it could be cancer of the colon or cancer of the anal canal. And also it could be an injury as a result of a swallowed fish bone or other fine material, fine food stuff. So that's the how we classify them, and we have to stick by that anatomical classification in relationship to the area. And in here you see the rectum, here is the anal canal, the transitional zone, and here's the dentate line. And we've got the internal sphincter muscles in here, and that's the external sphincter, and there's a space between them. And in that space where the perianal gland are situated, and they get infected, and the infection can spread to lead to a variety of other abscesses or eventually to formation of a fistula. Now, this condition is particularly common and affects people of all ages, more so patients are male and they are young. So how do they come clinically to the doctor? They would be complaining of perianal pain. So whenever there is perianal pain or lump, the abscess is on top of the differential diagnosis. Often, when you examine them, you will find they have a bit of cellulitis around the area, And the patient will report to you that they feel a bit unwell and their inflammatory markers are raised in the form of high white cell count and high CRP. Clinical examination on its own usually is enough to justify the diagnosis and take patient to theater for drainage. Now, we do sometimes utilize CT scans and MRI, and we use that in complex situations, particularly if we think there is cancer or there is a Crohn's disease or there is a complex fistula tract, which will help to delineate the anatomy and helps the surgeon to decide what sort of drainage or operation that particular patient needs. Now, the treatment, simply, we start the patient on antibiotics, and we usually prefer gram-negative and anaerobes cover, and that could be in the form of ampicillin or ceftriaxone in addition to metronidazole. We take them to theater under general anesthesia. We examine them thoroughly and make sure we know where the abscess is and its relationship to the anatomy of the area, in addition to its mainly relationship to the sphincter muscles and whether there is associated fistula or not. If there is nothing and it's a straightforward abscess, then we drain it by making a cruciate incision on top of the area that feel lumpy and fluctuant, and then we wash that area with saline and we pack it with a seaweed-derived package material. We leave the wound open, and then the patients will need to have redressing and packing in the community. Unless there is extensive cellulitis, usually a day or two of antibiotics will be, and the drainage will be enough. But if they have cellulitis or systemic features, we might need to prolong their antibiotics. So patients will go home often the next day, and then it will take them about 3 weeks for the healing process, and they will be monitored in the community, and the wound will be packed and looked after by a wound or community nurse. Now, we always ask ourselves in this situation whether there is a fistula associated with the abscess, because 30% of the times when you have a patient present with what clinically looks like a perianal abscess, they will have already a fistula. Now, the main thing that we try to do in this situation, try simple drainage if you are unsure, but if you are certain there is a fistula, you could deal with that either by laying the fistula open or insertion of a ceton, and I will come back to that later on. Now, patients with perianal sepsis, you need to be aware of them because obese patients and patients with diabetes, the disease can be complex, and every now and then we see patients with fournier gangrene or necrotizing fasciitis that basically started as a perianal sepsis but has been neglected and for a long time. And when I say long time, I mean a week or 10 days after their first symptom. So we need to be aware about these patients. They tend to be very unwell, and the necrotizing fasciitis is a major clinical issue. I hope in the future we will have time to discuss how to manage this. So that's basically the management in simple terms. And then I will demonstrate to you and show you what fistula is and the basic knowledge that you need to know about it. As we mentioned before, 25% of the perianal abscesses, they will have fistula at the time of the presentation, or it will appear later on after drainage of the abscess. The patient will bounce back with perianal pain, lumpiness, and intermittent discharge. And often when the pus get discharged, in these cases, the pain improve only to recur after a few weeks. The pathology is the same. It's infection of the perianal gland that lead to a abscess formation and a fistula formation. Now, we need to be sure that everyone knows what fistula means, the definition of fistula in general, not only in the anal canal. It's defined as any epithelially lined tract that connects to epithelial surfaces, and these epithelial surfaces can be skin and mucosa of the bowel, or skin and mucosa of the stomach, skin and mucosa of the esophagus, and so on and so forth. As I said, so it's intermittent pain. Patients usually feel well, but they feel a lump and there's intermittent pain and discharge. Often the discharge is purulent and stained with a little bit of blood. If you see complex perianal disease, and by saying complex disease, how do you know? You know when there are multiple fistula in different places around the anal canal. That raises the alarm for Crohn's disease, where you need to investigate the patients prior to any form of surgical intervention, and they probably need to be seen by a colorectal surgeon who has good experience in managing perianal sepsis and perianal fistula in patients with Crohn's disease. These fistula tend to be high and difficult to treat in particular. The perianal fistula has been divided into four groups, and the four groups that we talk about are really the relationship or the anatomy of the fistula in relationship to the sphincter of the anal canal. So that abscess could be that fistula could be intersphincteric, where the tract goes between the internal and the external sphincter and opens into the anal canal. So it is, that's the most common, the simplest, and the easiest to treat. And usually we treat this by a fistulotomy, where we cut down on the fistula over a probe that has already been inserted and leave it open for packing to heal, just like an abscess. The next one is transsphincteric, and if you see here on the picture here, is that the tract comes from the perianal skin in here and then goes through the external sphincter, then through the internal sphincter, back to the anal canal in the region of usually the dentate line. So that's an intersphincteric one. We'll come to the treatment of the transsphincteric fistula in a minute, because it's more than just laying open the fistula. Now, suprasphincteric is the tract of the fistula that evades the entire sphincter, and what happens is that it usually, the outer opening, you find it in the perianal region, and it tracks upward into the ischiorictal fossa and to the supralevator space above the actual sphincter muscle, and then back and opens into the anal canal. And there is an extra sphincteric, and this extra sphincteric has nothing to do totally with the anal region, because the opening is usually up in the rectum. And when you see a disease like that, you need to think about Crohn's disease and also cancers. Also, the suprasphincteric fistula, you need to be aware of the fact that some of them are caused by Crohn's disease, because majority of the other fistulae are either intersphincteric or transsphincteric. The suprasphincteric and the exosphincteric are the complex one. And how do we tell or find which fistula it is clinically? We do that by ordering MRI for the patient, and MRI of the pelvis and the anal canal is a very useful tool to delineate the anatomy in order to help the surgeon to choose the right form of treatment. Now, again, the presentation is the same as we said: purulent discharge sent by blood, intermittent with perianal lump, and often you see that we will ask for MRI of the pelvis. MRI is very available. In the past, surgeons used to do probing of the fistula, which I think is traumatic and can lead to formation of false track. And if there is any suspicion of complex disease, we should always get an MRI. And the benefit of that is that will show you, if you do a fistulotomy to lay the fistula open, it will tell you how much the fistula involves out of the sphincter muscle. Also, if there is a suspicion of Crohn's disease or cancer, then we do get MRI of the pelvis for better anatomy. Now, there is an old rule which is called the good soul rule, which is very effective in learning the fistula tract and its different types. Now, the good soul rule says that if the patient is put in lithotomy position, so upward is anterior, backward is posterior, or 6 o'clock, 12 o'clock, and then you draw a line, a section across the circle of the anal canal that kind of passes from 9 o'clock to 3 o'clock in that area. So that will divide the circle into two, anterior part and posterior part. Abscesses anterior to the line usually have straight line track, so you can expect when you pass a probe to test them, you can expect them to follow a straight track into the anal canal to the dentate line. However, if the external opening, external part of the fistula is situated outside the so posterior to that imaginary line, then they go into a curved track, and they all opens at the dentate line at 6 o'clock position, while the anteriors depend on where the abscess is. So the benefit of that is that if you see a fistula, the posterior half of the anal circle, you know the internal opening is going to be in the midline at 6 o'clock position, and that's where you look for it under anesthesia. But with anterior fistula, the fistula will follow a straight track, so it could open anywhere in the dentate line, but it will always be on the anterior half of the circle. Now, I'll try to keep the treatment as short as possible. So these patients, we, after getting MRI and clinical examination and ruling out the possibility of having Crohn's or cancer, and taking their past history of perianal sepsis or any surgery done in the past in the anal-rectal region. We examined them under anesthesia, and we could use either methylene blue or hydrogen peroxide. We use a fine drawing needle, blunt tip, and we just inject the methylene blue or the hydrogen peroxide. I do prefer the hydrogen peroxide because it doesn't stain, and you can repeat it as many times as you can. And we inject through the external opening while the anal canal is open under anesthesia with a proctoscope. And we watch and see where the bubbles of the hydrogen peroxide come, which will help us to probe the fistula. Now, often the surgeon will, once they probe the fistula, they will be able to tell whether this is intersphincteric and we are not sacrificing any muscles. Then they cut down on it, curate the track of the fistula, lay it open, and keep the dressing process for 3 to 4 weeks, similar to the abscess, to encourage healing with the granulation tissue from the base upward. Every now and then the fistula can be transsphincteric or suprasphincteric, where it involves a significant part of the external sphincter. In this situation, it's a judgment call, and if the surgeon have a young patient, particularly male, and the abscess at the posterior half of the anal canal, even if it involves up to 25% of the sphincter muscle, that can be sacrificed and divided. It will heal by scar tissue and pull things together, and unlikely to end up with incontinence. So that's the limit. How do you assess that? That's a matter of experience, so we leave that for now. But it's also important to know that in women, the sphincter muscle is a lot weaker and smaller than men, particularly on the anterior wall of the anal canal. So if there is any fistula in the anterior half of the anal canal in a woman, we should almost always try to treat it with simple measures or insertion of a C-tone to be followed later on by an internal advancement flap, so we don't sacrifice any sphincter muscle. And then what will happen, so that we put the C-tone in, which is a rubber tube. It goes like a circle around the sphincter muscle and through the fistula tract. We tie that down, we leave it for about 6 weeks or so, and then we do the advancement flap. And the external part of the fistula, you will see the surgeon will try open it as much as possible without damaging the sphincter muscles, and we keep it open so the packing process will continue for the granulation tissue to cause the healing, and we review them. And if we are planning to do a mucosal advancement flap, we try to allow about 6 weeks before we do the second stage to remove the C-tone and do the mucosal flap. I thank you for staying with me, and I look forward to seeing you in future videos. Hopefully we'll keep coming. I think the next topic will be perianal abscesses, and I will see you then.